So already there are 2 single piece implants. They are in the patient mouth for more than 14 years. They are functioning well and good. Now we are planning for screw retained solution, so we are removing and we are going for 6 implants standard. R-on-4 also possible, but to prevent any prosthetic complication due to high chewing force, we are adding molar implant also. So we will see the reformatted view. So we have to remove all this old implants and this tooth supported bridges. Okay. First we will plan for the right side tilted implant. So this mesial implant is the first, maybe second premolar. Okay. There is a bone loss around the mesial implant. So from that we are tilting the implant mesially. Okay. So we are tilting the implant mesially. And we are checking whether the nerve is safe. Keeping the nerve safe is very simple. Just to draw 5 mm in front of the mesial edge of the mental foramen. So stay away from that 5 mm. You will be safer. Okay. So in this defect, from the edge of the defect, we can start our tilted implant. So left tilted implant will be starting from the socket of second premolar mesially. How much tilt to give mesially, it is, we can easily analyze from the clinical surgical point of view. From the mesial edge, mark a point 5 to 6 mm in front of the mesial edge of the mental foramen. Draw a mark starting point from above the mental foramen. So connect these 2 points and follow the line during drilling. So 3.75 into 16 or 18 depending upon the availability of length. The 2 anterior implants, the trick is just to follow the lingual wall. Just follow this angulation, you will be in a good favorable prosthetic position of implant and ME abutment. 3.75 into 13 or 15 will be better. So both side axial implant. This is classic R-on-4. So we will be adding a implant on the for molar. Either we can place implant through the implant. After removing the implant, we can through the socket of the implant, or we can go distal. Anything is fine. We can see the nerve here, canal is coming there. We can safely place a 12 mm or 10 mm implant. Okay. So to be on the safer side, we will be placing the implant distal to the implant socket. Here the challenge will be only the crestal bone is cortical. This bone is fully hollow. So we have to keep the implant at the crestal level. If we submerge the implant below the crest, the implant will sink into that osteoporotic bone space. And then retrieving it will be a difficult thing. So we have to keep the implant at the crestal level. The stability will be a little challenge because only the crestal bone is cortical. But the left side seems favorable. The canal is also favorable. This is the first molar area, maybe long-term edentulous. There is a resorbed dip is there. Up to 12 mm implant we can safely face. Here the bone quality is quite alright. Some radio opaque thing is there, but still it is marrow. The crestal bone is somewhat good. The crestal bone is around 500 HU. So that's it. Surgical sequence will be you remove this implant and remove the opposite canine and finish these implants, then go for the other side, or remove all the implants, do alveoplasty to all the lower jaw and finish the implants. Both is possible.